Well, afternoon, and thank you very much for inviting me to speak, Alexis, and for the excellent organisation of today. I've been asked to talk particularly about Bedford Hospital and our successes or perceived successes in reducing our healthcare associated infection. I do think, however, that this could apply to many, if not all, acute hospitals, and hopefully I'm representing the work a lot of my colleagues have been involved in as well over the past few years. So some of this will not be new to you because I'm sure you've done it in your own organisation, but this is the way that we did it in ours. I've also renamed my session Stealth Transformational Leadership in a Transactional World. And the reason I've done this is because we do have a very transactional National Health Service, in so much as top-down, you will do. We have targets to meet. We're all very familiar with this. But I think that if we want sustainable change, we need to think differently about how we deliver our patient care and services to our patients. Top-down management, it used to make so much more sense than it does now. And that was probably because the need for change was slow, because the environments were perhaps fairly stable. And it might be then that the people at the top did have the best view and the best and the most important information as to what needed to change. In the past, business, social and political environments did require less change over longer periods of time. In such environments, the underlying reality of chaos is hidden. And here I managed to get a little bit about snorkelling in, because an ocean with riptides deep under the surface and life under there teeming with little battles between fish and everything else that goes on underneath the ocean, from the shore looks relatively calm. And maybe a few years ago, this is how the healthcare service, and with particular regard to infection, looked. We were very much a Cinderella service for many years, I think we feel. But then suddenly, this is what we see. We all remember these in the papers. Some of them are fairly recent, really. This is our tsunami, I think. This was our underwater volcano that had an effect and was noticed by everybody in the UK, and I think that was echoed internationally as well. Our patients were not getting the best care from us. Our patients were dying from infections that could have been avoided. I know how that made me feel, utterly helpless, overwhelmed. And there was this sea of change because it was unacceptable, I think, to all of us in healthcare, certainly unacceptable to the public we serve, and became politically top of the agenda, didn't it? This is my view of what happened. We had this incubation period, I think, that we knew from our surveillance, both mandatory and our voluntary surveillance that we submitted in infection control. There was this incubation period of resistant pathogens. And then we hit this crisis point, and it was management of that crisis that we've seen particularly over the last 6 years, I guess. Containment and recovery. We're all very familiar that our MRSA, bacteremia, and our Clostridium difficile numbers have fallen dramatically. I think we've still got some questions over other healthcare-associated infections that we need to do a lot of work on. But we've certainly, in one sense, recovered. Some organisations have come under additional scrutiny, really, such as Stoke Mandeville, Maidstone and Tunbridge Wells. We're all familiar with this. And specific inquiry looked at cause, why has this happened? And essentially attributed blame. And then there's the drawn-out inquiries, and then we look at change and implementation of change from there. potentially all a bit late for a large cohort of patients. All these things take a lot of time. And we could look at it like this. There's learning the lessons, there's the passive learning from inquiries, and then the implementation of change, the active learning thereafter. What I would propose is that we can certainly now do both at once to take things forward nationally and certainly within our own organisations. And this is, I believe, well, it's easy in hindsight, isn't it, what we tried to do at Bedford Hospital. Looking at the last 5 years, we've reduced our hospital apportioned MRSA bacteremia, if we reapply the current criteria to old numbers, by 91% in 5 years, which 17 patients less in a year who get an MRSA bacteremia through being in our hospital, whether it be avoidable or unavoidable. This is a snapshot of interventions that we took to expedite that. And I'm going to talk more about those later. I'm sure you can't see some of that. But a lot of it was looking at the evidence base, what we know causes or contributes to a bacteremia, an avoidable bacteremia, and what we can do to stop it. Huge evidence base, really, for a lot of this. But I think what we're lacking is the link up with how we make that real for our staff. It's very easy for a lot of us in infection control because we know we've done the reading, we come to conferences like this and we have the opportunity to learn, but how do we then share that learning with the people delivering the care? Similarly, with Clostridium difficile, at one point in 2006 to 7, we were one of the worst hospitals in England for our C. diff numbers. Absolute crisis point, not fully appreciated by the organisation at the time until a support visit from the Department of Health. We all had separate pieces of information, and it was one of those, I think the railway industry call it a signal passed at danger. The trust board thought one thing, the infection control team thought another, that we had flagged things up well and truly. But it was how the information, the clinical governance was arranged that really sort of made the situation quite difficult. So we were trying to manage in pockets of intervention really, rather than a system-wide approach. For example, I think we were one of the first implementers of a Clostridium difficile isolation unit, which helped tremendously, but it wasn't the whole picture. We eventually managed to implement some quite strong changes around our antibiotic policy, for example. I think that was one of our probably main success stories. And around engaging staff delivering care in reducing infection. This is our most important thing, and I think when we reached crisis point, we set about, what do we actually want out of this? Our vision was and is no avoidable infections. And I'd suggest, if you haven't got a vision, then what are you doing? What's the point of being at work really if you don't know where you're going? And a vision, again, is great, but then you need the very detailed plan about how you're going to achieve it. This is what we did. We put together an infection control programme that consisted of, originally we were called a turnaround team for healthcare-associated infection. We're now called the HCAI Action Group, not the most exciting of names, but we've now been meeting for 3.5 years on a Thursday morning at 8:30, and we've still retained our membership. And I think we still have great momentum within the team as well for working together. And we are not trying to manage infection control in a top-down way. the team members are evangelists. They are out to sell and win hearts and minds of our staff. That's our goal, really, to realise our vision.